clue from this. So let's look a little bit of combined HCC and CCC. So this is a review article about liver transplantation for mixed HCC and CCC from South Korea. So this table shows a summary of many centers data with mixed HCC and CCC. So as you can see, the numbers are very small out of all liver transplantation. So most centers reported liver outcomes with a small number of patients, less than 40. So each center showed different outcomes. The one-year disease-free survival rate were around 50 to 80%. However, the 5-year overall survival rates were reported from 16% to 73%. So why so different outcome from hepatocellular carcinoma? I believe this is because every center has different protocol and different selection criteria. In this paper, the most cases were diagnosed after liver transplantation. Diagnosis of combined HCC and CCC before liver transplant were rare because most of the mixed HCC and CCC were considered as HCC only before liver transplantation. So absolutely mixed HCC and CCC shows worse outcomes than HCC. As a treatment option, liver resection versus transplantation is still controversial. So there are still no definite selection criteria for the combined HCC and CCC, but we surgeons feel that unresectable tumors, underlying liver cirrhosis, and relatively younger age can be a good candidate for liver transplantation. So I'm going to briefly introduce my center's data about combined HCC and CCC. We performed 29 cases of liver transplantation for combined HCC and CCC, 21 LDLT, 8 DDLTs. There are only the pre-LT biopsy performed for 5 patients out of 29. So these are the outcomes. 57.1% of patients had recurrence after liver transplantation within 5 years. The recurrence tumors occurred in many organs. So this is overall survival. 5-year survival rates were only 49%. So out of the recurrence tumors, 66.7% happened in 1 year and 91.7% in 2 years. So most of the recurrence occurred within 2 years. So future direction, I don't have an answer, but after all, selection matters. So to select the good candidate for liver transplant, we should consider 2 aspects of tumor. The first, for tumor burden-based selection, so we should check tumor size and number, which is very traditional. Second, for biology-based selection, we should do neoadjuvant chemotherapy to watch response. So recently, some reports showed gemcitabine-based chemotherapy without radiation therapy can help getting good outcomes like 100% 2-year overall survival and 75% of 5-year overall survival after liver transplantation. And we should expand checking tumor biology with multiple biomarkers like these. So I would like to summarize this topic. So liver transplantation for intrahepatic cholangiocarcinoma is still controversial, but an evolving strategy to treat IHCC. So some benefit from liver transplantation can be obtained in carefully selected patients, such as early-stage tumor, cirrhotic basis liver, and younger patients. Neoadjuvant and adjuvant chemotherapy has been developed to improve post-liver transplant outcomes for advanced intrahepatic cholangiocarcinoma. So patient selection should incorporate biology